Hi everyone, it's René here from JJ&J, and for June we are talking about inotropes. And although we use that term quite loosely, this is all about vasoactive drugs. So inotropes and pressors, we're going to give you all the ins and outs of this very important topic that crosses beyond cardiacs to ICU in general, and even further, critical care. So this is for a much bigger audience. And I hope that after this you feel more empowered to manage these drugs and confidently wean and increase them as well as needed, and be part of the multidisciplinary team to make better clinical decisions. So what are vasoactive drugs exactly? So when you start in ICU, you kind of have this perception that it's blood pressure up and blood pressure down. But these drugs work on all different adrenergic receptors within our sympathetic nervous system. And it depends which receptors they activate or antagonize, which has a different effect in the body. And we have different medications that do this job. We don't have 7, 8 different inotropes that are all just blood pressure up or down. They work in different parts in our body and all have very different affinities for certain receptors. So it's important for us to know the difference, know what receptors do what and what medications will do what, to make sure that we are administering the right medication for our patient's pathophysiology. The right mechanism needs to be selected. And when we have multiple ones on a patient, if they had a lot of issues, we should know which one to focus on to wean first. And this is the knowledge that we're trying to impart on you guys today. Okay, so let's recap. We've done cardiac output in a previous month, but let's recap this one slide and the equation, the mother equation of cardiac output, so that we can understand this again. So remember, cardiac output is heart rate times stroke volume. I'm sure you all know this by now. And stroke volume is made up of 3 factors, and that is preload, which is all about volume, contractility, how powerful that ventricular squeeze is, and afterload, which is how much resistance the ventricle must overcome to squeeze out the preload. Okay, so how does this pertain to the inotropes and vasopressors? So if we have a problem with, for example, our heart rate, something that we could initiate is either pacing or positive chronotropy. Remember, chronotropes will be medications that will increase our heart rate. So the more times the heart beats, the better the cardiac output will become. On the stroke volume side, if we have an issue with our preload, and I'm talking about, in all these instances, I'm talking about a negative or a decrease in all of these things. So if we have a too little preload, we could measure our CVP and our cardiac output monitoring, and then use goal-directed fluid therapy to replace that fluid and ensure that our preload is adequate. That's how we manage preload. Contractility, this is where we come in with our positive inotropy, and we'll start a medication to increase and stimulate the heart to beat harder or squeeze in a more powerful way, which is another way of saying increase contractility. For example, adrenaline infusion. If we've got an issue with an afterload that's too low, we need to give our patient vasopressors to increase the systemic vascular resistance. So increase, or should I say, decrease the diameter of our arterioles, for example, so that there's a higher pressure that the heart needs to beat against, which will increase the perfusion to the rest of our body. Remember that we're talking now when we have issues where it's too little. We don't want it to be too much, because that also gives us also gives us issues. So if we have a too high afterload, the left ventricle will take strain, but we're trying to get to a more normal picture. So if our patient is pyrexial or septic or vasoplegic, we're going to have a dilated patient, which is going to have too little afterload, and we need to tighten them up again, and we use vasopressors for that. Okay, and if we cut out some of that equation and just look at today's focus, we're looking at the stroke volume components of contractility and afterload. And contractility is all about inotropes, and afterload all about vasopressors. So types of inotropes are adrenaline, dopamine, dobutamine, isoprenaline, and milrinone. And we use these drugs mostly when our patient has heart failure. Okay, and it increases our myocardial contractility. Vasopressors, we use them to increase our afterload or vasoconstriction, and the reason for this is usually shock. And examples of these medications are noradrenaline, vasopressin, phenylephrine, and methylene blue. So coming back to our adrenergic receptors, remember these are the receptors that are all over our body and form part of our sympathetic nervous system. There are different types, and we need to understand where they are situated and what they do if they are stimulated. So I want us to focus on the three at the top of this slide, which are alpha, beta 1, and beta 2. There are others. We've got V1, V2, and dopamine, but let's focus on those top three for now. So our alpha receptors are found in smooth muscle, and if they're stimulated, they cause vasoconstriction. And where do we find smooth muscle? It's throughout our whole body. Yeah, but not in the heart. Our heart has specialized muscle cells. This is in our vasculature, basically. Okay. B1 or beta 1 is found in our cardiac muscle. So if we stimulate those adrenergic receptors, we get inotropy and chronotropy. So we get a more powerful squeeze and we get a faster heart rate. So these are the ones that are going to give us that increase in contractility. Beta 2, they are found in our lungs and also the rest of our blood vessels. And if they're stimulated, they actually cause vasodilation. And this is a very important one to note because we do want this if our pulmonary vascular resistance is high. Okay, and then the last three, which we're not going to focus on that much, they're a bit less common, but we've also got V1 adrenergic receptors, which are also in our smooth muscle, also will cause vasoconstriction. V2 is in our renal, which will cause an antidiuretic effect and retain water. And then we've got our dopamine adrenergic receptors, which are in our mesenteric, renal, and coronary arteries, which will cause vasodilation if they are stimulated. So it's very important to know these because our inotropes all work in different parts here, and we need to choose the right one for our patient's problem. Okay, so welcome to the mother load of slides. This one we'll send in the group so that you have it handy at the bedside as like a pocket card, digital pocket card, and a quick reference. We've included most of the common inotropes and vasoactive drugs that we use at the bedside in the critical care setting. And you'll see them listed there on the left. And then we've got our adrenergic receptors listed on the right, and the plus signs are how much affinity that agent has for that specific receptor. So many of them have got multiple adrenergic receptor ability to affect them, but they have a greater affinity for certain ones, which means, for example, if we look at adrenaline, it also is quite a unique vasoactive agent because it changes its affinity from low dose to high dose. So a low dose adrenaline is classified as 0.05 micrograms per kilogram per minute, and anything above that is classified as high dose. And I'll just mention now that the majority of this slide was compiled from the American Heart Association's information. There's an updated version of this which you can have a look at on their website, but most of the information was taken from there. Okay, so let's talk about that low dose adrenaline. So at low dose, it's got a less affinity for alpha. And remember, if something has an affinity for alpha, it means that it's going to vasoconstrict our smooth muscle, and it's going to give us a higher afterload, and our SVR is going to increase. And then it will become like a pressor. But at this low dose, you can see that its highest affinity is for B1 or beta 1, which is in our cardiac cells, and that will increase our inotropy or contractility, making this an inotrope predominantly. So at low dose, we can say adrenaline is an inotrope. But as soon as you go over 0.05 mics per kilo per minute, it changes its nature and it has a stronger affinity for those alpha adrenergic receptors, and it becomes a pressor. So I hope this example demonstrates to you how important it is to know the dose of your inotrope. Especially look at this one where it changes from an inotrope into a pressor. If we look there, it also has a function on our beta 2, and at a lower dose it has a higher affinity for beta 2, and it vasodilates our lungs and a little bit of our blood vessels as well. But as soon as you go higher, it has less affinity there for beta 2, and then no effect on the V1 and 2. And our standard dose range, which like I said was taken from the AHA, we say a low dose adrenaline is from 0.01 mics to 0.04, and the high dose is from 0.05 to 0.1, with an ultimate maximum of 0.2. And I'll show you an example a bit later of what we've sort of noticed in this region and how we do our administration of inotropes. So we'll come back to that. But that's adrenaline. So another popular one is noradrenaline. And if you have a look there, it's very different to adrenaline in that it has a very high affinity. And the highest you can get is those 5+, and it's got that for alpha, making it a pressor. It also has beta 1 and beta 2, nothing on the V1 and V2, and the standard dose is around 0.01 to 3 mics. So it has a much higher doses allowed of noradrenaline, but 3 mics is at the threshold there. Okay, phenylephrine is a very interesting one, and one that we must remember. It's got that high affinity for alpha, just like noradrenaline, but it does nothing for your cardiac, nothing for lungs, and then obviously nothing also for V1 and 2. So it's got a very niche role, and it only affects our alpha adrenergic receptors. And the reason why we try to avoid this one in cardiacs is obviously because of that no support for the cardiacs, not supporting the contractility at all, and only being a powerful vasoconstrictor. It increases the workload of our left ventricle dramatically because it only increases afterload. So they kind of use this in cardiacs for a very specific purpose, and that is only in emergency situations when we have done some work on valves where our myocardium is used to a higher blood pressure, and if that blood pressure drops, the patient can cardiac arrest. So they use this as an emergency drug in that situation. So it has a very specific job, but we try and avoid it as a continuous infusion to try and manage blood pressure because it doesn't give any other support to our beta 1 or 2. So we try and avoid phenylephrine in cardiacs. I also wanted to mention for noradrenaline, this is the drug of choice according to the Surviving Sepsis 2023 guidelines. It's our first line vasopressor for sepsis. So you guys can refer to that. And then another one that we see quite often is dobutamine, or more commonly known by its trade name as Dobutrex. And this one is also quite interesting. It does have properties for alpha, but its main one is beta 1. So this is actually an inotrope, and it has some affinity for beta 2 as well. So they use this a lot in heart failure because it does help beta 1 and 2. So it will vasodilate your lungs, you'll have decreased pulmonary vascular resistance, and it also assists with contractility as well as chronotropy. It's got a wide range here, 2 to 20 mics per kilo per minute. And we must be careful if we're going into those higher doses greater than 10 mics per kilo per minute, that we take into consideration that this also vasodilates our blood vessels on that beta 2. So it can drop your blood pressure. It's a powerful vasodilator which has its uses for the pulmonary side. But if you start giving a big dose, you could actually be dropping your blood pressure unintentionally, and you might need to add a vasoconstrictor, which is a bit counterintuitive. So just remember, Dobutrex at high doses, it works on the beta 2. It's also in your blood vessels, and it dilates. Beta 2, once it's activated, is a vasodilator. So it's going to decrease your afterload, making the diameter of your vessels wider, and it will drop your blood pressure. So watch out for that. Next up is dopamine, and this is also one of those interesting ones which changes its nature at a low and a high dose. It's not used as commonly anymore because it's not as safe as the others which have very similar effects. So it's kind of currently known as a more old school approach. We don't use it as much anymore. But if you do come into contact with dopamine or intropin, as we know it from the trade name, a low dose is regarded as less than 10 mics per kilo per minute. And at that dose, it's an inotrope. So its highest affinity is for beta 1, which we know is in our cardiac cells. So it's going to help with the inotropy of your heart, or this powerful squeeze. You'll see there it's got an affinity also for beta 2 and then less on alpha. If you go beyond 10 mics per kilo per minute, it changes its nature and it becomes a pressor. You can see there the alpha has gone up to 3 pluses, and our beta 1 is still the same, but it's now increased its affinity for alpha. So that once again, so important to know the doses and not just the mils. Okay, and then in the unique one, vasopressin, this one doesn't have any affinity for our alpha beta 1 or beta 2. It works on V1 and V2 alone, and it's a powerful vasoconstrictor. It's given at a fixed dose of 0.04 units per minute, and it's usually in conjunction with something else. So usually if Dobutrex and milrinone are not working and not maintaining enough cardiac output, they might add a vasopressin, but very uncommon on its own. It's usually given additionally if we're not able to manage the cardiac output adequately with the alpha beta 1 and beta 2 agents. So check that one out. Okay, then the last one that we're going to discuss on its own a little bit later is milrinone, and you'll see that it doesn't work on any of these adrenergic receptors. It's quite a unique drug, but I did want to put it in here so that you've got the reference for the standard dose, which is 0.375 to 0.75 mics per kilo per minute. So a question, why is dose so important? And I've put this in because in our region, the culture of inotropes and these vasoactive drugs is to give it on a pump, but at mils per hour only. And it's a problem. And why is that a problem? So vasoactive drugs are weight dependent and are triggers for further clinical decisions. If a maximum effective dose is reached, a mechanical intervention is necessary. And continuing to just increase your inotropes or vasoactives is actually futile for your patient, which I'm sure you've seen. If you read any literature and follow any guidelines or any science-based practice, you will see them refer to all the inotropes in dosage. And to be expected at the bedside to be making these calculations on the fly, doing maths during a crisis, it's extremely inconvenient and unfair in an emergency situation. We really should get into the practice of programming our pumps before we administer the medication, or if you're in a terrible emergency, start the medication and then program the pump. But we really should do the maths in the initiation of the drug so that everybody's on the same page and we can monitor the dosage continuously on the patient and make relevant clinical decisions. We're in an area where we do have mechanical support, talking about ECMO, and there's certain levels on the inotropes which will trigger those decisions. And if we've got inotropes on a 50 kilogram patient or a 90 kilogram patient and it's running at mils per hour, it's very difficult to actually know where you are according to the dosage. And I'm going to discuss this example with you now. So let's have a look. Let's talk about adrenaline. And we said, according to the AHA, the maximum dose of adrenaline is 0.2 mics per kilo per minute. And in cardiacs, we say even less, 0.1. And 0.1 is actually the trigger where you start to think about what else can be done for the patient, and you should actually be consulting the ECMO team. It's a warning that there's something wrong with your cardiac patient. I'm talking about the post surgery setting, for example, or even cardiogenic shock. The patient might require more support. And instead of going up and up with inotropes, because we know the adverse effects, we know that it causes organ dysfunction because there's not enough perfusion and you get necrotic arms and legs and all sorts of things, we rather offer the patient mechanical support, press that pause button, come down with our inotrope load and sort out the patient's problem. Okay, so let's have a look at this adrenaline. So we're running this adrenaline, and I've calculated this on the average mixing regime that I've noticed in the hospitals that we work at, and that is 4 amps or 4 milligrams of adrenaline in 46 mils of saline to equal 50 mils. So if we use that recipe and we're running the adrenaline at 10 mils per hour, on a 50 kilogram patient, that equates to 0.27 mics per kilo per minute, which we already know is way above the maximum dose. On a 90 kilogram patient, it's 0.15, which is different. It's not hit that maximum, even though you're in trouble for your cardiacs if you need so much adrenaline. But those two dosages are very different. It's almost double. And your instincts are not going to be able to determine these things just by having the information of 10 mils per hour. Okay, let's take a further scenario. So say you've got these two patients that are on their 10 mils per hour of adrenaline and they start to recover and they're looking better. And the doctor says to you, let's wean the adrenaline infusion, and you're the ICU sister. I'm not sure that there's any protocol that explains to you how, at what increments to wean. I've chatted to a few of you sort of on the side, and a lot of you said some doctors will say wean 0.5 mils per hour, and some of you wean 1 mil per hour. And if your blood pressure is very good, you'll even wean 5 mils per hour. And the same goes for if your patient's in trouble and you've got hypotension and you want to give more inotrope. Also, what increments do you increase your adrenaline at? Same story from you guys. Some will go up 1 mil and then see where the patient goes, or some will go from 10 to 15 mils. And that's an enormous jump if you have a look at the dosage. So let's say you're weaning at 1 ml per hour, which seems to be the average. And you're on that 50 kilogram patient, 1 ml per hour is 0.03 mics per kilo per minute. And on the 90 kilogram patient, it's going to be 0.015. So it's completely inconsistent. So your standard of 1 ml per hour has a very different effect based on the patient's weight, which we're not even taking into consideration. So if you've got a smaller patient, they're going to be weaned more aggressively, obviously, and a larger patient will then automatically be weaned more conservatively, just because we're not taking the dosage into account. So if you've programmed your pump according to the dosage, it's much easier, and you can wean your first attempted weaning can be 0.01 mics per kilo per minute. And if it's tolerated by the patient, you can then go up to 0.02 at a time. But so you have a lot more control. But if you're just using the volume, it has a very different outcome depending on the size of your patient. And that is not a scientific way to do things. I've said this so many times. In ICU, what does the I stand for? Intensive. We need to be specific, calculated, scientific about the way we're treating these patients. These drugs are life support in a sense. We can't just be guessing at what the dosage is and not being specific about the weight. Okay, so let's see if we carry on with this example. And like I said, if you're in trouble now and your blood pressure is low and you want to increase, if you take that big jump from 10 mils per hour to 15 mils per hour on that small patient, the 50 kilos, you jump from 0.27 mics to 0.4 mics, which is enormous and way out of range of what is recommended for adrenaline. On the 90 kilogram patient, you'll jump from 0.15 to 0.22 mics, which is then now over the recommended max as well. But you can see the difference there. Soon that 50 kilogram patient is going to have purple toes. And we won't know because 15 mils means something totally different according to the size of our patient. But if we're monitoring the dose, it will quickly stare in our faces that we're way over the limit. We can't put a limit on mils because it's not based on weight. Okay, and then I also just wanted to show here at the end, remember we said adrenaline has two natures according to the dosage, and a low dose adrenaline under 0.05 mics is considered an inotrope. Above 0.05 mics, it changes into a pressor. So what is that limit on these two patients? So if you're carrying on with your mils per hour pump on the 50 kilogram patient, that adrenaline will change its nature at 2 mils per hour. Under 2 mils, it will be an inotrope. Above 2 mils, it's going to be changing into a pressor. On a bigger patient, the 90 kilo, for example, that threshold is going to be at 3.8 mils per hour, which is completely different. And you're not going to know unless you're making these calculations all the time, and nobody has time for that. We should program our pump, take a little bit of time, a minute, 2 minutes to program our pump, and then this is all sorted for the rest of the duration of this drug. And we can see on the screen the dose as well as the volume. So the screen will then say, for example, 0.05 mics per kilo per minute. So you know where you are with the adrenaline, that you're still having it as an inotrope, and that you're giving it 2 mils per hour. That will still be available to you guys. So you can then chart the fluid intake as well as 2 mils. It will give you both factors. It's completely doable, and we need to change it urgently, not just for cardiac patients. This should be a general practice in all of our ICUs. I also just wanted to add there, If you look at the Alfred's guidelines, which we use a lot for our ECMO clinical decisions, I've taken a little screenshot there and you can see the clinical trigger and timing of VA ECMO, they refer to the adrenaline of 0.2 mics per kilo per minute, which goes right under our noses if we're giving only mils per hour. Okay, so we've come to our milrinone now. And if you remember from our chart about the adrenergic receptors, it had zero effect on any of them. But milrinone is a powerful inodilator, but it works in a different way. So it's definitely a vasoactive drug. It's in this category, but it's not the same as the others. The other ones that we've discussed, also very important to mention, they have a very short half-life, as I'm sure you've seen. If you've ever had the experience of one of those drugs running out, you'll see an effect on your patient very quickly. But milrinone is different in this regard. Its half-life is much longer. So the message is, if you are titrating milrinone, don't treat it the same as your other inotropes or pressors, where you can go up and up and up or down in quite a fast way. Milrinone takes 15 to 30 minutes to have an effect. So if you make any changes, slow yourself down and first observe those changes, because if you go up too soon, you might have a combined effect that's way too high or something that you didn't expect. So if you wean every hour, and if you increase, don't increase more than every half an hour on milrinone. First wait. Okay, but how does it work? So it is a little bit complicated. I don't expect anyone to remember this in too much detail. Milrinone is a phosphodiesterase inhibitor. And how it works is it increases the CAMP available in the cell, which ultimately increases the available calcium in the cardiac muscle. And if we have more calcium, we've got those calcium channels open longer, we have an increase in contractility. So that is definitely inotropy. On the smooth muscle side, it does dilate, and it's much more powerful than the beta-2 dilation that we have from our other drugs. It might cause a drop in BP because of this, because it is more powerful in its dilation properties, but it's very, very good for pulmonary hypertension and right ventricular failure. So heart failure, right-sided heart failure, so that calcium channel increasing, that available calcium and increasing the contractility is going to help your right-sided ventricular failure, and the dilation properties are going to assist that pulmonary hypertension and relieve some of that high pulmonary vascular resistance. But because of that dilation property, just watch that even though you're expecting this to improve your cardiac output, it might cause a drop in blood pressure. So sometimes milrinone does need a companion to help with that. The maximum dose, or the dosage recommendations, is 0.375 to 0.75 micrograms per kilogram per minute. And like we've already discussed, watch out for that increased half-life. It's not as quick as the other inotropes that we're used to. Okay guys, so that wraps up what we wanted to convey today about inotropes and pressors, or vasoactive drugs. I hope that you have learned something today, and perhaps that you have more understanding of why we have all these different types and how they work. And of course, the gold standard is to measure your cardiac output. So do your cardiac output monitoring and integrate those data points with how you make these clinical decisions. So for example, if your SVRI is very high, the normal values, remember you can access them easily on the machine. So say your SVRI is high, you've got a high afterload, target the pressors, target the agents that have that affinity for alpha, and wean them first. If your cardiac index is low, and you're trying to get more inotropy on board, have a look at that chart again and look which agent has got that affinity for beta-1. That's the one that's got the inotropic properties that's going to help your myocardium to squeeze harder. Of course, before you touch pressors or inotropes, make sure you've got adequate fluid balance on your patient. And this, you also can't just give fluid willy-nilly. Have a look at goal-directed fluid therapy, have a look at your CVP, have a look at your SVV, and make decisions together to give reasonable amounts of fluid at the right time when the patient needs it. And once that's been done, adjust your inotropes and pressors accordingly. And in the same way, if your patient's improved and you now need to wean these drugs, you need to choose whether you're going to focus on the inotropic ones or the pressor ones first, based on your patient's clinical picture. And if you're lucky, you'll have the cardiac output monitor to help you and you don't need to figure it out. I hope this is all starting to make sense and you're starting to put this all together. I'll see you guys in the units for more information, and please follow us on TikTok for some more pearls about inotropes and pressors. Thank you so much for watching. We'll see you around. Bye.